Robinson, and I'm a student in a doctorate in athletic training program from Indiana State University. Today I'll be discussing a comparison between myofascial release and positional release. So to begin, the basic point of myofascial release is a manipulation of the myofascial complex to restore optimal length of connective tissue, or if you want to get specific, the fibers in our fascia or the sarcomeres, overall release pressure on pain-sensitive structures and improve function. So we want to lengthen those fibers, and in that process, that will decrease the pressure from the built-up tension or tightness of the tissue, and overall decrease pain and improve function. So this type of release can be used to treat a wide variety of conditions ranging from injuries to general muscle tightness from sedentary lifestyles, to people that are active and constantly contracting their muscles for certain exercises. So this general release can be applied by involving a slow and sustained pressure towards a restricted or tense fascial layer or layers. And this can be done directly or indirectly. So direct myofascial release is where the clinician or the patient utilizes their knuckles or elbows or fingers and other body parts to apply a small force or pressure over the restricted area. Usually that's where the pain-sensitive area is, and stretch it in the direction of the fascial restrictions. The indirect application is just applying the stretch with very little force, and do that along the path of least resistance until the fascia loosens. So you're almost kind of avoiding that restricted area. Myofascial release can be performed with a clinician, or there's also self-myofascial release, like I've already mentioned, where the patient can do it. So for example, for plantar fasciitis, a clinician can cup the foot in a certain way and utilize their thumbs to apply pressure and or a stretch towards the restricted fascia or towards the least resistance pathway, like the indirect version. The patient can have similar outcomes by placing a tennis ball underneath their foot and allowing some pressure down onto the tennis ball and rolling the sole of the foot over the tennis ball. So the tennis ball is not only the foot is not only applying pressure on the tennis ball, so there's pressure over that fascia, but the tennis ball rolling back and forth on the sole of the foot is kind of like that stretch technique. So positional release therapy, also known as strain counter-strain technique, uses the position of comfort of the tissue or surrounding tissues to resolve somatic dysfunction. This type of dysfunction is caused by a hypersensitivity of the stretch reflex in our muscles, leading to a disturbance in the sensory system that results in spinal segmental tissue facilitation and inhibition. That's basically a mouthful of fancy words to say that the stretch reflex is hyperactive, and that will eventually lead to knotted or restricted tissues that can ultimately lead to pain, spasms, and loss of range of motion. So the goal of positional release therapy for this dysfunction is to unkink those tissues by gently twisting or pushing tissues into a close and comfortable position, basically releasing that tension. So this is the opposite of stretching, basically. So for positioning, if when you focus on a tight and tender area, the clinician will place that muscle or tissue area in the shortest length possible, so opposite of stretching, leading to a relaxation. And they do this while palpating the tender area. So palpating the tender area, that's where the patient hurts. You place them into a comfortable position, and that means that this is the position of comfort where they either have a lot of the pain levels have decreased significantly, or they no longer feel pain in that tender area at all. And then the clinician, the reason why they're palpating as well is to be able to feel that tender area relax while they put the tissue area in a shortened position. So this position is usually kept for a varied amount of time, but typically suggested in certain studies for about 90 seconds before the patient may change positions or the clinician will work on other areas. So since I've already gave the example of plantar fasciitis, I decided to look up and see what I could find about comparing myofascial release versus positional release for the treatment of plantar fasciitis. And I found 2 clinical trials that compared both therapies. So this is a lot of writing, but basically the first column is the methods of the first study, the second column is the methods of the second study, and they're very, very similar. So the first study had 60 participants and had 2 groups that those participants were equally but randomly divided into. Group A was a myofascial release group where they had ultrasound applied to the sole of their foot for 5 minutes, and then they had the myofascial release technique applied using the heel cup and thumb technique, and that was done for 10 minutes. Then after that, the patients were required to do tennis ball stretching technique, so basically self-myofascial release. And then they did some strengthening exercises for their intrinsic foot muscles. The myofascial release group did their treatment once a day for 10 days, so 10 treatments total. Group B had the same exact process as Group A, so ultrasound and the exercises / stretching after, and then in between they had positional release therapy done instead of myofascial. The patient was lying supine. They had mechanical pressure applied over the tender area, so not a lot of pressure, just enough to feel it. And then the foot was placed in a position of comfort, so this typically involves plantar flexion. And then in order to find where the area of pain decreased by 70%, so the pain levels of the patient decreased by 70%, they rotated the foot in different directions to find the most comfortable position for the patient. Once they found that position, it was held for 90 seconds 3 times. And then afterwards, like I've already said, they went through the same exercise that Group A did, and then they did this combination of treatment also for 10 days in a row. The second study was very similar in that both Group A and Group B had myofascial release and positional release done almost in the same way. So Group A, they had ultrasound done for 5 minutes, and then they had the myofascial release technique done for 10 minutes, and it was done in the exact same way that the first study did theirs. Group B had ultrasound again, and they had positional release, which is also done in the same technique as Group B of the first study, but this time for the second study, it was only held once, that position of comfort, for 90 seconds, and only once, so not 3 times. And then the difference between these 2 groups versus the Group A and Group B of the first study is that they did not have any follow-up exercises or stretching techniques. Lastly, Group C was a stretching comparison to compare against Group A and Group B. They also had ultrasound for 5 minutes. The patient was supine while the ankle was moved into dorsiflexion to stretch the gastroc. So that's a typo, I'm sorry. And then the knee was bent while the ankle was dorsiflexed to stretch the soleus. Passive plantar fascia stretching was also performed on these patients. And overall, all the stretches were done for 30 seconds, 3 times each. So Group A, Group B, and Group C all had single sessions. That means that whatever you see on this slide is what they had one time, and that was it, unlike the first study where they had this repeated for 10 days. Looking at outcome measures, the first column is the first study again. So the visual analog scale and the foot function index was used for the first study. So that was to measure pain levels and function. So that was the patient-reported outcome. And overall, there was a significant decrease in pain and a significant increase in function from the 1st to the 10th day. So they did pre-measurements before the very first session, and then they did post-measurements after the 10th session. And there was no statistical difference between the groups, however, so that means there was no difference really between the outcomes of myofascial release versus positional release. The study made an interesting claim about how ultrasound was a vital part of these results. And then they referred that to a couple other studies that were done in the past. However, this study had no control group, so I kind of took that with a grain of salt on whether ultrasound really had that strong of impact or not. The second study looked at the VAS scale again, and then they also looked at range of motion, ankle range of motion, instead of a patient-reported outcome for function. So the range of motion and pain scale were both measured pre and post interventions, so right before and right after each patient got their intervention. And then the VAS scores significantly improved in all groups, and there was no difference between the groups. So for pain, the stretching group was just as effective as the positional release as the myofascial release group. All three groups also improved in dorsiflexion, and the only statistical difference lied between the myofascial group and the positional release group. It didn't say in what way that was statistically different, like as if dorsiflexion was better in myofascial release versus positional release. It just said that there was a statistical difference. And then all three groups also improved in plantar flexion, and then there was also a statistical difference between myofascial and positional release groups, and then the positional release versus the stretching groups. So overall, the bottom line that I got from these two studies was that both the myofascial release and the positional release therapies can be used to overall decrease pain, improve range of motion, and improve function for patients with plantar fasciitis. Both seem to be effective for short-term outcomes, but long-term outcomes were not measured with either of these studies. And then also both, from reading the studies, I kind of took away that both should be combined with other modalities or exercises for improved outcomes. Like I said, the first study really attributed ultrasound as a vital part of how the results were significant, even though there was no control group. And then the first study also utilized exercise right after each treatment, which I would personally do anyways in my own clinic. So that is the bottom line overall. Both seem to be effective. These are my references. Thank you for listening to this presentation.